Okay. Hello, everyone. This is Jeremiah Johnson. I'm the chair of the Young Neurosurgeons Committee. Today, we're going to have I believe this is our 13th webinar for the NREF Young Neurosurgeons webinar series. Today's title is Applying for Post-Residency Neurosurgery Fellowships. We have a really amazing set of guests, and I want to give them as much time as possible to chat about this topic. In addition, we have great panelists, and we'll get to all that as well. But I appreciate everyone coming. We just wanted to, with this webinar, we just want to make sure that we can provide information that's not necessarily out in a book somewhere, but is something we can pass down to residents, students, and young neurosurgeons to help them understand how to better move towards a career in neurosurgery. We're a subcommittee of the AANS and are the kind of the conduit for you people that have not been certified, including medical students, residents, and young neurosurgeons, roughly under 5 years of training, out from training. And we are in the business of helping get our word and what we think about the field known to the AANS and molding new leaders in neurosurgery. The AANS stands for the American Association of Neurological Surgeons. It's a scientific education association with more than 10,000 members. Its goal is to guide the field of neurosurgery, and roles include education and advocacy and promoting the highest quality patient care. Finally, NREF is the not-for-profit organization created by the AANS that supports basic science, clinical research, as well as lifelong education to foster improved outcomes for our patients with neurosurgical diseases. In addition to that overall introduction, they spend a lot of their time and energy helping educate residents and students through NREF courses, and this is an extension of that, so we're very thankful for their support. Just want to remind everyone, we do have an episode on April 8th. That'll be a little bit more medical student focus. It's a field guide to the neurosurgery match process, with the emphasis being on how to master your sub-Is and how to approach them, and as well as the interview process. And we'll have several speakers, including Dr. Van Gompel from the residency program coordinator in Mayo, and look forward to that. All right, quickly for our panelists today, Dr. David Dornbos, he's the YNC Vice Chair, Cerebrovascular Fellow, at University of Tennessee in Memphis. If you've watched these webinars, you've seen him a few times. He's one of our great leaders in our committee. Dr. Christina Wang, who is currently on our committee as well. She's a fellow at the Department of Neurosurgery Cleveland Clinic. Welcome, Christina. And then Angela Richardson, who's a skull-based fellow and Department of Neurosurgery, University of Wisconsin. And welcome, Angela, as well. We'll get to our guest. I believe Dr. Grant is going to join us in a short while. He's on another call. But I tried to make these introductions in order of what I believe to be roughly the most senior to most junior. So I'm sorry if I got this out of order a little bit. But Dr. Grant, he's a professor and endowed chair at Stanford. He's a division chief of pediatric neurosurgery, and he directs the Pediatric Neurosurgery Fellowship. We've intentionally, of course, invited people that are fellowship directors to talk about the process of getting into fellowship in these various subspecialties. You can see his training there. He went to undergrad at Duke University, residency at University of Washington, and his fellowship at Seattle Children's. He has a very interesting career where he went into actually the military service for 7 years, which is a whole nother topic. And then he eventually made his way back to Stanford. Dr. Wang, professor at the University of Miami Neurosurgery. He's the director of neurosurgery at the University of Miami Hospital. He's also the spine neurosurgery fellowship director. Good to see Dr. Wang. He's very well known in spine circles for being an innovator in minimally invasive spine, as well as many other realms. You see his training there, Stanford University for undergrad, residency University of Southern California, fellowship University of Miami. Thank you, Dr. Wang, for coming. Dr. Mocco, he is a professor at Mount Sinai Neurosurgery. He's the vice chair there. He's also the director of Cerebrovascular Center Fellowship. His studies were primarily at Columbia University for medical school residency. He also got a master's of science in biostatistics there. And then he did his endovascular cerebrovascular fellowship at University of Buffalo. And so welcome, Dr. Mocco. I appreciate you coming to join us. And then finally, Dr. Raza. He's an associate professor at MD Anderson Cancer Center, Department of Neurosurgery. He's the vice chair there. He's the director of the minimally invasive skull-based fellowship. And you can see his amazing training, of course, as well. Dr. Johns Hopkins for medical school and residency. He did a neuro-oncology NIH-funded fellowship during his residency, as well as 2 postgraduate fellowships, one at intranasal skull base at Cornell and one open skull base fellowship in MD Anderson. And he's the director of the skull base fellowship there. And thank you again for joining us, Shaan. All right. With that over, I just wanted to say one more thing about our incredible student who helps us plan and execute all these things behind the scenes, Anna Amendaris. And I want to thank Anna as well as Becky Struer, who's here from NREF, for all their incredible support to make these possible. All right, so for today, rather than formal presentations, we're thinking of doing a bit more of a chat type format. So I'm going to exit screen share. And then Dr. Grant was kind of be first, but since he's still not on the call yet, we will start with the next in line, who I believe is Dr. Wang, if I'm not mistaken. And if I got you guys general finishing training backwards between Dr. Wang and Dr. Mocco, I'm sorry, but I believe that's the order. So we wanted to have a couple of basic questions and leave time for question and answer at the end for specific questions from the audience and from the panel. There's 2 kind of subdivisions of types of fellowships that we have represented here. And we think that between those 4 types of people, most of the issues relating to postgraduate fellowships will be addressed. So the kind of group of fellowships that is centered on you must do a fellowship to practice this type of subspecialty, and that would be like pediatrics and endovascular. And then there are the fellowships where you could potentially get this training in residency without a fellowship and practice it on your own, but there are still very good reasons to do fellowships in these areas, and spine is one of those, as well as skull base and neuro-oncology. And so we're going to kind of like, for some of the questions, kind of break them up along those grounds. So with Dr. Grant not joining us yet, as far as I can see, we'll start off with, at least for this first question, with spine and then skull base and oncology. So I was going to ask Dr. Wang, what is the general reason why someone would consider applying to a spine fellowship, given that they do spine cases in residency? What is the impetus in your mind for someone applying for those, and how do they do it, and when do they do it?
Yeah, thank you, JJ, and thank you for the panelists and YNC for doing this. It's amazing. I wish I had this resource when I was a resident. Jay and I believe we're the same year, right, Jay? We finished medical school at the same time. Anyhow, so I think if you look at spine, right, 70% of all neurosurgery is spine. So technically you should be getting plenty of training and residency in spine. There's really 2 reasons you should do a fellowship. The first is if you're at a program that's a little bit lighter on the clinical realm and you feel like you didn't really get what you needed out of it and you need a little more confidence finishing school, there's more to being a neurosurgeon than operating, going to clinic, seeing and managing your practice, managing your environment, the OR. Those are pieces you pick up in a fellowship that will make you better and more confident, right? So that's a very important box for some people to check. Other folks are looking to become like a super powered private-demic or academic person. And for those folks, and I think we'll get into this later, right? They're really trying to get to the upper echelons or get refined or get connected, do more research and et cetera. And we'll go into that deeper, I think, later. So those are the 2 big categories, I would say.
Awesome. I think similarly, I'll just get Dr. Raza's thoughts on why folks do these fellowships in his field.
Sure. I think building on that, I think they're good clinical reasons and also reasons from the mentorship perspective. So, from the clinical perspective, I think if your desire is to be able to tackle some of the most surgically challenging cases in skull-based or neurosurgical oncology, if you go straight from residency and into practice, you really have to end up in the right practice to get along that learning curve. And you got to end up in a practice where it has the right number of cases, right frequency, and right surgical mentorship. By doing a fellowship at another program aside from your residency program, you're spending a year with a department or a faculty member who has already honed their skills. And I think it pushes you further along that learning curve much faster. And you also learn a different skill set, right? So you have an opportunity to sort of question dogma that you were taught during residency, and you learn a different way of doing things. And I think especially relevant to oncology, by spending that year of fellowship, you really get a good handle on multidisciplinary care. I mean, that's the nature of the world that we work in now. And so, the more well-versed you are with regards to systemic therapy, adjuvant therapy options, indications, relative risk and benefits, then you're going to be much more a better well off in terms of leading a tumor board and actually interacting with those other subspecialties. And I think this really applies sort of across the board for neurosurgery. And then there's a mentorship perspective. When you do your residency, you certainly join that family when you graduate. And when you do your fellowship elsewhere, you join another family. And so you have another set of mentors that are going to look out for you, whether it's a sounding board for tough surgical cases, or when it comes down to trying to get promoted and getting letters of recommendation and that sort of thing. So many reasons to do a fellowship, even if you've had a great skill-based and oncology experience during residency.
Very well said, I think, on both parts. Dr. Mocco, I know people that want to do endovascular have to do an endovascular fellowship, but anything you would add to this discussion from that perspective?
Well, I would emphasize that the points that were just raised by the two prior speakers, they're just as important as any skill set that you're going to get in that endovascular cerebrovascular fellowship. I would say that even if you train in spine with Mike Wang as a resident, it's still worth going to do a fellowship somewhere else. Not because Mike isn't amazing, he is, but as both of the prior individuals emphasized, there is so much value to seeing how someplace else does things, what their decision making is, all of the little tiny nuances that go into it. As I get older, I get a lot less flexible, not just physically because I'm not a yoga practitioner, but also in your mindset. And the investment of a year or two before you really started your career, when you still have that flexibility of mindset, of career, and of opportunity, it pays invaluable dividends down the road. So yeah, I think they hit the nail on the head.
Awesome. This is a little bit atypical for our usual format, but I just wanted to get maybe Christina's thoughts on what she's benefited. She's currently in a fellowship. What has been the benefit she's had? She's doing a spine fellowship now.
Yeah, hi everyone. I think Dr. Mocco was just talking about how you get more rigid and less flexible. I'm not as far into my career, but I'm also getting more rigid and less flexible. But I think comparing last year to this year now, your chief year, you're managing a service, you're managing, people, you're managing complex cases, and you're trying to stay alive and succeed and do well and multitask. I think the nice thing about fellowship has been I only have to focus on spine. I don't have to think about aneurysms. I don't have to think about shunt malfunctions. And so you really get to clear your mind. And I think bring a perspective of what will my workflow process be? How will I work these patients up? And you get to sort of imagine and spend this year preparing, for how you're going to go into practice, as opposed to sort of being everything is coming at me. I just have to figure out how to take care of this patient. I have to schedule this case for tomorrow. Someone's crashing. So instead of trying to put out fires, you're just sort of kind of sailing a little bit, and it's much less stressful. So I think the mentality of this transitional year is really helpful.
Angela, how has your experience been in your fellowship, and are you happy you did it? And what are some of the things you've learned maybe we have or haven't mentioned that you think are important?
I've been very happy I did it. I think it's been a great experience thus far. In this fellowship, I actually take attending call, which is really nice because it's sort of a nice transition with, I guess, a safety net in some ways. I think the questioning of dogma is particularly interesting because certain things are managed just differently other places. And that's outside of the fellowship. Just some of the trauma management that I've seen in my fellowship versus what we did in Miami has been different. And so it's really interesting to learn these other ways of managing problems that you're just so institutionally biased from where you trained. We didn't really use pentobarb that much in Miami. We did different things for ICP. So it's just adding more tools to your tool set, even outside your fellowship, which I think has been unexpected for me, which I've really appreciated.
That's great. I do want to dig into one thing that I think Dr. Raza specifically mentioned, which is the idea of mentorship. And at least in my career, like everyone kind of mentioned, or several people mentioned, is that the is that having an additional group of people that are not only your friends and family, but also your advocates when something comes up that you need their help with. And that can be anything from, boards and certification to jobs or being, pushing someone to give you some sort of position somewhere. These things are very important, particularly in academics, but I think it holds across. So that's one other thing I would mention in addition to pure mentorship, like seeing how a master does it, or someone who's excellent does it, or a new skill set you may gather in growing a new family in neurosurgery, like a bigger network. I do think that there is also like a very practical importance to that, particularly in academics, that I would like to highlight as well. Excellent. I want to kind of talk about from someone who's like a junior resident who decides they want to do a fellowship. What is the timeline in the different subspecialties? I think that's something that kind of vexes a lot of people. Some people decide they want to do a fellowship in their 5th or 6th year, and they may be scrambling to find one. Some people send out their, letters to different fellowship directors, maybe a little early, and then they kind of get forgotten. I just want to kind of go through the process of sort of going through that initial stages of timing and mechanics with each of the different fellowship directors. So maybe we can go in reverse order this time. Maybe we can start with Dr. Mocco. When do fellows in your mind need reaching out for an endovascular fellowship?
Right now, it's a bit of a free-for-all. There's no clear organization of the endovascular, supravascular fellowships. I have heard of and seen programs that are in, supposedly securing spots 5 years ahead of time. I personally think that's foolish. I think there's too much that changes in life, and it doesn't make much sense. As a rule for our program, we've decided to try to not fill spots more than 2 years ahead of time to give people that flexibility. But that comes with its own detriments. I know someone who reached out recently, seemed like a fantastic candidate. And then, I wrote him back and said, hey, we'll follow up. And then 6 months later, wrote him back and said, okay, now we're going to start looking for that year. And they said, oh, I already took a job somewhere else because they offered it, and it just happened. So once you start talking to people, sometimes it'll happen. I will say that there is a move afoot through organized cerebrovascular societies to organize a match. And so that's news to everyone. I don't think that's really out there yet, but there's a multi-society effort to coordinate a neurovascular interventional match. That probably won't take effect for 5 years from now or so. So no one needs to freak out. And it'll be done in a staged and reasonable manner. But I think in the end, it'll be much better for applicants so that people don't feel pressured to accept a position as a PGY3 for something before they've ever even started doing high-level cases. In general, it'd be nice if neurosurgery had a moratorium as a rule of letting people, make their picks till they're senior residents and have really done the cases and manage the patients and have more of that insight. But that's just my own 2 cents. It's not worth much more.
No, I think that's a great direction to head in general. I think it would make the chaos of this as fellowships are becoming more and more common, I feel like, and settle it down a little bit if that could be had. So in your, just to kind of back calculate for folks to make it, very simpler. So 2 years out. So this is someone in their PGY 5 year that would be applying to your fellowship, or their 6th year? Yeah,
we're interviewing for 2023. So that would be 2 years. So PGY 5, right?
5, yeah, 5. Yeah. I think that's pretty in endovascular, I believe. But like you said, there's gonna be some variability. Mm-hmm. Okay, great. How about Dr. Wang? What is the spine fellowship? When do people start reaching out, and when should they reach out? And when is too early? When is too late?
Yeah, I really like what Jay said, because Jay's correct about the fact that your maturity and the maturity of the situation of the program you're applying to can change overnight. And he's right that it would be, in an ideal world, you would do it about 2 years, 18 months before. And if you look at, for example, the NAS match, that's how it looks. But the reality is that this is a competitive process, right? So you go through life for college, then medical school, doing this thing where you compete for spots and then you get to choose. And then you go to this match process and you're now back into this mix where it's like you apply to a place and people can say, I want to give you a spot. You can back out at the last minute, all these things. So we in Miami, we generally are interviewing 4 years ahead of time. And I had a conversation, it's very interesting. One of the young people was asking me like, is that really even fair? Like I'm a PGY3. I don't even know for sure that I want to do this. And you're saying, and how have I even built up my CV for medical school that you can even judge me? And that's just one of those harsh realities that if you want to do a fellowship and I really admire what Jay's saying, because his fellowship is very competitive. People are going to compete for the folks that are going to be very successful as fellows. And I will add another dimension in neurosurgery spine, which is there are a lot of orthopedic fellowships that would love to have any neurosurgery resident. They will kill for a neurosurgery resident because you are so much better than an ortho resident. And I have my own political feelings about that. If you want to get controversial, JJ, we can get controversial. I think it's ridiculous. I think that, if they're not going to train their own people, why would you want to train with them? Not to say there aren't amazing orthopedic spine surgeons out there that are world renowned. But our PGY7s are better than their 4th year attendings, right? So that's a reality, right? So what I would say is that generally in spine, the good fellowships, they're filling up about 3.5 years before the fellowship time. And I think in spine, there's just so much flow. There's so much bulk. There's so much chaos because there's so many positions and so many people applying. I think that's one of those issues, right? So maybe as you get more rarefied, it might be a little less chaotic, a little more focused.
Can I second on that? Because I think Mike makes great points. It's true. It's a competition and there's definite competitive advantages to taking people early. It's reasonable. It also opens up a question. A few years ago, a prior mentee of mine called me up because he was going to a fellowship and the attending that he was going to do the fellowship with left the program. In fact, this happened twice in the last 3 years. And one place, the guy really didn't have a good spot for him where he was going because it was that year. So we scrambled. He wasn't even my resident anymore. He's one of my old residents from Vandy, but we found him a really great opportunity separate. And likewise, one of my prior residents was going to do a fellowship with Lawton to see a different way of doing open vascular. And Mike left and went to Barrow. Mike was able to bring him, and he was able to be Mike's first fellow down there, Justin Massatelli. But this is life. Things are going to happen. It's going to be back and forth. I think if organized neurosurgery can do something to simplify and straighten it out, that's great. But when all said and done, it's fair game to do whatever you can to do your best for yourself and for the field.
Awesome. Dr. Raza, what does it look, the field, the timing and the mechanics of applying for your fellowship look like?
Unfortunately, it's all over the place. At MD Anderson, for both our skull-based fellowship and our neurosurgical oncology fellowship, we're on the later side. So we interviewed in the fall of your PGY 6 year for a 7-year residency. Though I think when you look at skull-based, there's some fellowships that accept residents in their PGY 4 year. Though I think a bulk of the fellowships are really in their PGY 5 year. And then otherwise, when you look at the general tumor fellowships, it's basically the end of your PGY 5 year and the beginning of your PGY 6 year when they'll interview folks.
Yeah, I think this is super helpful to give everyone an idea of how this works in multiple places and multiple fellowships across the country. Let's see if Dr. Grant has made it on, not just yet. I'm very curious to hear I want to make sure he talks about how the pediatric fellowship works, but whenever he can join us, we'll get his thoughts on that. So just kind of this for summarization's perspective, it sounds like Dr. Mocco's fellowship, and I'm not saying it's the same for all of endovascular, but roughly PGY 5 you apply. Dr. Wang, as early as PGY 3, maybe PGY 4 is even late. And then Dr. Raza's group, maybe PGY 6. Sound fair?
I mean, but I do think there's a point to be taken.
All right.
Jeremy, sorry. I was going to say, I think there's a point to be made that if you know what you want to do early, if you know what you want to do early and you're competitive, then probably looking at opportunities early, if those spots will take you, may be a benefit. I think that kind of comes across to some degree.
You know, Jay, let me add another dimension, because I'm looking at the attendees, and a number of them are from the UK and Australia and other places. Would you comment on that as well, or would Shaan or Jeremiah comment on that? Because I think it's an important differentiation for the non-US trained folks, right?
Mhm. Well, I'll
Yeah.
start. We've trained a lot of people from OUS, a number of Australians. I'm trying to think of a guy from India who went back to India. I like the idea of bringing our knowledge sort of to a global community and global audience. So I don't think targeting a post-residency fellowship is necessarily a great way to be an entry point to come from OUS to try to practice in the US. I think that's a little tougher, but that's my 2 cents.
I'm going to echo that also. I think over the last few years, we've started taking more and more fellows from outside the US with the intent that they go back to their healthcare system and practice there. And it's a way to sort of, for us to expand our global footprint. So, you know, we're definitely in favor of that.
Yeah, and in spine, obviously, that's an easy entry point, right? Because if you do enough fellowships in the US, you might get a license. So we see that a lot in spine. So for example, in Miami, we'll maybe take one person out of the 6 fellows that's going to be international. So for those folks, they've got to really start early, because the spots are so limited.
That's great. I just wanted to kind of get one like very practical question, which is that, you know, how do people generally apply to you? Just an email? Do they have a mentor call? Like how does this standard, is there a standard way that this works when it comes to applying to your fellowships?
You know, at MD Anderson, we have a pretty formal application process. It's, you know, you got to do CV, 3 letters of recommendation, and, you know, the transcripts and things like that. I think a lot of other skull-based fellowships, though, are not as formal. I mean, it's usually just say email from a mentor and a CV. So I think, you know, sort of paying attention to the program, I think, helps with that aspect.
Dr. Mocco.
Yeah, we do. We also have a CV and 2 letters of recommendation, but the process starts with an email. The other thing I'd say is you shouldn't be worried to be a little persistent. I think all of us are awfully busy, get lots and lots of emails, and sometimes, despite our best efforts, something slips by. So if you actually don't hear anything, don't assume that Dr. Wang is ghosting you, but rather that just he's the busy man that he is, and just send the same email again, just a brief follow up and connect. Because I do it. You know, we didn't talk about this, but at least in the current non-match type fellowship system, chance plays a role. Chance plays a role in who sees it, who they've taken already, what's happened. Did somebody, you know, just quit when they were planning to go? Plenty of people get their fellowships as a PGY7 because someone's life situation changed. So be persistent. Don't be annoying, but be persistent.
Well, Jay's correct, and chance favors the prepared mind. And this is where I'll make the plug for the in-person meetings, like go to AANS in Orlando this year. Like, you know, seeing someone in person at the bar or at a session, talking to them is worth 100 emails. Because you got to understand that the folks here, you know, you may think you're busy, but, you know, if you get over 1,000 emails a day, it's kind of hard to really sort that out and keep everything straight. And you can't put a name with a face and all that. Go to the meetings, meet folks. Who knows? Maybe you're not going to like them, right? You never know what's going to happen. So meet them in person, and that's where you really can make a connection. You're going to be like shoulder to shoulder with these people. I mean, Jay, you're in the OR, like in the endovascular suite, like all night with these people, right? So you kind of want to like them. You kind of want to be around them. That's, to me, the best way to do it.
I was an associate professor before I realized that I could meet Mike anywhere but a bar.
Only on Zoom now.
All right. Well, I see Dr. Grant joined the fray here. So just to catch you up, Dr. Grant, we've kind of gone through an introduction to the different types of fellowship tracks that are represented here, with the exception, of course, of pediatrics, and have talked a bit about timing and when you apply and some of the nuances of how to apply. Since you've joined us, maybe we can just kind of backtrack a little bit and get your thoughts on how and when someone would apply to the pediatric fellowship. I know it's more of a unique situation in pediatrics than it is in some of the other subspecialties, but we wanted to get a flavor of kind of a smorgasbord of the different ways that it's done.
No, thanks you. I really appreciate you putting this on. It's a great idea to get everyone together thinking about this. And I'm sorry I'm late. We were on another couple AANS calls that Wang was avoiding. And this is really saving the best for last. I mean, peds is clearly the best subspecialty out there. And actually, Mike wanted to be a pediatric neurosurgeon for years before he spine, pulled him in. But, we were together as medical students, and back then he wanted to be a pediatric neurosurgeon. So he still feels like he's missing out, but, that's a little bit different in peds. It's a post-residency matched fellowship. So that marks it a very different sort of entity, right? You talk about cast probably already and things like that, infolded and whatnot, but peds, you're basically applying into the match, and you find out where you're going basically in December, of your chief year. So you're basically reaching out to programs as an R6, somewhere about May timeframe, something like that. And like, it was mentioned in terms of, an email to a program, hey, I'm interested in your program, what's required. And, it's all pretty simple in terms of what was mentioned, nothing different. And then there's a formal match. There's about 30 fellowship programs in peds, which are too many. There's about 4 to 5 that probably go unfilled every year. So it's competitive, but it's really competitive for the top places, right? That really you're attracted for people to go. But you hopefully will get to go somewhere, because there are international fellows that will still are interested to join. And but everyone has to go through the match. There are programs that aren't part of the fellowship, but you could still become a fellow at, but they're not part of the sort of matched fellowship program by the San Francisco match. So that's pretty interesting. Now the ABPNS, which is the American Board of Pediatric Neurosurgery, they merged with the ABNS, the American Board, which is a really good thing. So now basically if you do your fellowship, as you become board certified, you do the pediatric module as well as the general sessions, and you become board certified and pediatric board certified all at the same time. There's no separate whole process anymore, because it's really just one shop. So that's really important, I think. And, I think being post-residency, it just changes the flavor a little bit, that if you're not in a program that has a lot of pediatric work, or you don't have a fellowship at your site, you really want to do the networking like Mike was talking about at the meetings, and go to the peds section, which is common as an R6. A lot of people attend that peds section meeting in December, a year before the match. That's a very important meeting to attend, or to present that if possible, and network at the CNS and AANS meetings for sure, at the peds subspecialty sections. But it's really a tremendous group of teams around the world that do pediatric neurosurgery. You get to do some really amazing things, and it's quite unique, I think, in terms of how diverse you could be in terms of what you do, even though you have subspecialty niches, whether you do fetal neurosurgery or brain tumors or epilepsy or pediatric sort of spinal deformities, really interesting niches. And the fellowship programs are all a little bit different in terms of highlighting unique aspects, but every program has to be able to do everything. You can't just do brain tumors here, say. You have to be able to do everything to be a certified fellowship program. It's not ACGME certified, so that's something that you might find unique. The reason is you become a clinical instructor at many sites, so you become an attending. And you couldn't do that if you were an ACGME fellow, the way the boards rule. So just keep that in mind. It's actually a benefit to be able to start cases, have your own clinic, things like that, but it's not in the ACGME sort of fellowship pool, even though you're in the match. So any questions, please put them in the chat.
That's a great overview.
Or ask, yeah.
Yeah, so that's what this is a perfect segue. Anyone who's on the call who has questions for these this panel and our speakers, just put the into the question and answer chat, and we'll try to answer your questions as we go or at the end. It's like my internet's slow. Everybody hear me okay?
Yeah.
Okay, great. So something that's been mentioned a few times in this discussion, and I just wanted to kind of clarify it a little bit, and I'm sure it varies depending on the program, but in your guys' mind, what makes a competitive applicant for your fellowship? Maybe we'll start again with Dr. Grant and then go to Dr. Mocco, Dr. Wang, and Dr. Raza. What are you looking for? CV, the mentors who train them, the location they train, the program they trained in, what recommendations, et cetera. What is it that you look for to make a competitive candidate?
Yeah, I think it might be unique in PEDS because it's a clinical fellowship year. A lot of people say, oh, can I do this kind of research during the year? And, it's really focused on, if you're an R8, you're really trying to get that technical expertise, learning microdissection at that next level. You're training the residents, the first time, maybe as a young faculty member. So I think that's a very unique thing that for me, like I looked mostly for the passion of just wanting to be a great sort of masterful surgeon in PEDS. That's to me is one of the most important. And that comes from a lot of the mentorship in your program, which who we're going to reach out to about whoever it is, him or her, to kind of learn that passion of just being a great surgeon. It's not so much destined for an academic career it's really just about being a great masterful surgeon wanting to be the best they can be. And we stress that early on in the interview times that it's not so much the bench work they did, that doesn't really carry you during that year. So that might be unique from some of the other ones. I'm not sure.
That's great.
I think we make a good 1-2 punch because I think I'm going to go a very different direction. I don't think that the world necessarily needs a plethora of more neurointerventionalists. It certainly could use some better distribution of the ones we have. But as a result, I'm not looking, I'm really looking for people of specific excellence, not necessarily benchtop, but broad excellence, not only technically, but also in terms of wanting to become leaders in the field and contribute. Because I think that to me is more what we need right now. So I am pretty acutely looking for that. I want people who are going to want to contribute. They can do that in a private environment. They don't need to be in academics, but I would like them to be the kind of person who is going to make a difference to the field and publish or be a leader within the organized bodies, or somehow do something additional on top of the technical skills that I think are an absolute necessity to go through this experience. And I always refer to, so then as a result of that, I look for two things. Number one is, are they a good person? Do I enjoy talking to them? Are they reasonable? The other is, I think of a quote from Bill Parcells when someone asked him about his ability to evaluate top tier linebackers. And he said, if they don't bite as a pup, they're not going to bite as a dog. Meaning, you have to look at what they've been doing. And so I do look at their CV. If the person hasn't been productive and hasn't done the sort of things that show they're going to be a leader in the field as a resident, then they're unlikely to do that as a fellow or as an attending. So that's what I look at and think about.
Yeah, I kind of would echo what Jay says. I mean, it's not really fair to say that someone in their first 3 years of residency, which are the hardest, at least in terms of hours, is going to be able to get like 50 pubs in the first 3 years. And it's just not really fair to them. So to that end, I agree with Jay that we're looking in spine usually for someone with real heart, someone who is teachable, someone who wants to learn, someone who's committed to whatever that element is. Doesn't have to be academics, can be private, couldn't be privatemics, could be a lot of different things. But that feature is essential. Now, the thing I would add is that how do you define or recognize that feature? And I think it goes back to, this being a relatively small network of people, and it's in their recommendation letters. So, maybe you have a ton of papers, but everybody hates you at your own program. It's probably going to come out in your letters. So, that element of like, are you doing well in your residency? Are you the kind of person that volunteers for extra? Are you going to stay late? Are you going to, do what's needed for the patient? That is really what I think most spine fellowship directors really, really want. And everything else is gravy, right? You write papers, you got a grant, you're good looking, you're, able to, you're able to do this and that with your hands. That's all great. But having the right heart, it's like, if you have the right motivation, you can turn anybody into a Navy SEAL, right? I mean, Jerry would know, Jerry's Air Force actually, but you would know like what that person would be, right? Because they're willing to be able to take the extra effort and do things right. So that would be my pitch. So if you haven't published enough, it's not too late. You can be that person. You can be that most desirable candidate.
I think from the skull-based perspective and the neurosurgical oncology perspective, I'm going to echo a lot of the points that were already made earlier. What we're looking for is a fit for our program. There are a lot of skull-based and general tumor fellowships out there. We view our responsibilities to not only teach the full spectrum of surgical techniques, but also multidisciplinary care. And what we're looking for is someone who is not only wants to be an outstanding surgeon, but is going to take advantage of the resource of a large cancer center. And along those lines too, we're looking for folks that are going to push the field forward. We used to traditionally look for translational researchers, but now we're looking for folks that are well-versed in clinical trials design or cadaver research, because there are a lot of different ways to advance the field, and we sort of want to play a small part in that. And, we're also looking for somebody that's going to teach us something. I think we're very fortunate that we have a lot of qualified residents that apply for the fellowship. And so somebody that has a unique skill set or a unique sort of fund of knowledge that we may not have in the department, we're going to look for that because they may be a potential faculty recruit too. And that's sort of how we view our fellowship process.
That's great. I think that all very, very good thoughts. Very good. I do have one last question, then we can go to kind of a bit more of a discussion format with the panel, and you can answer some of these questions. So someone's gone through a number of interviews at your fellowship, including your fellowship, and it's kind of their time to make a decision in their mind, and they decided that your program's their top choice. What should that person do? Wait to hear from you if it's also they're your top choice, or should they somehow indicate to you that they're your top choice? And if so, how would they go about doing that, Shaan?
I think a phone call from a mentor and an email from the applicant goes a long ways in terms of showing that interest in the fellowship.
Dr. Wang?
Yeah, I think those are all excellent points. I would just reiterate the ones that are already said, because I think most of it was already covered.
Sorry, I lost you there for the end, but I'll just assume that was an awesome answer and move to Dr. Mocco.
Yeah, I think communication. Look, and if you've got a mentor who has a relationship, or an attending at your current program has a relationship, that can reach out. I think that also is certainly a good way to stay in touch and be connected. Dr. Grant and Dr. Wang recently trained some of my prior residents that we reached out to them for and said, hey, these are good people, and if you could do it, it'd be great. And that's always a plus.
Awesome. Dr. Grant?
Yeah, I agree. I mean, it's great if the communication, just like as a residency, it comes from the applicant first. I would love to hear from the person. It's a little bit awkward if it comes from, a mentor. And I said, oh, I didn't really hear from the other person yet. So you want to put your first foot forward, like really let people know you want to go there. It's a little less demystifying than like the residency application process, where there's much more of a relationship you develop. The interviewing process is longer. It's a little more intimate. It's a smaller team. And I think that makes it more fun. At the fellow level, I think a much more of a two-way street, and really understanding like, okay, this is a really good place for me and why. And it's very mutual, it feels. It shouldn't be a big surprise, like which fellows you get in your program. You just feel very compatible. And I think that's a plus of the fellowships, because at that point, you're senior enough, and you kind of get to know yourself better in terms of what you're after. And it's not like you're so undifferentiated as a medical student, you really have no idea. You're a lot more focused, which is really helpful, I think, to understand where you're going. And I think we all appreciate that as mentors too, but it's definitely a two-way street. We want to feel like it's a good place for you and vice versa.
Perfect. David, we haven't heard from you yet. Tell us what happened when you were interested in joining with Memphis, and how did you go about that process?
Yeah, I think my kind of process through all that was very similar to what they were all kind of alluding to. But the biggest thing for me was just connections between my home program and Memphis. I kind of decided so I did my residency training at Ohio State, and I kind of decided a little bit late to do a fellowship somewhere else. I've been planning to stick around for just a 1-year kind of postgraduate endovascular fellowship just at Ohio State, because I had done a year sort of enfolded, had enough cases anyway to get a year under my belt. And it was really beginning of my 6th year where all of a sudden I kind of talked to a bunch of folks and kind of came to the realization that I wanted to do my fellowship elsewhere. Really nothing against Ohio State. The older I got, I guess I got a little bit wiser and started to realize that I really wanted to get a different range of experience, just a different way of doing things, a different type of expertise. I fortunately for me, I had been planning on going into vascular, so I had already done a fair bit of research in that area, and it kind of beefed up my CV on the vascular side of things. So I was kind of, I guess, at those boxes checked. But then I realized I had Russ Lonzer at Ohio State, my chair, reach out to Adam Arthur down here, because they were both residency buddies and they knew each other, still know each other very well, and just had him put in a phone call and a good word for me, and went down there for an interview. I interviewed a couple other places, and they were also very similar. I got in late, but just through connections that I had at Ohio State, them reaching out to their old mentors, just putting in a good word for me was how I ended up making that switch. So, and I guess that's one thing I'd like to ask the group is, I was planning on doing a year enfolded and then just stick around for a 1-year postgraduate fellowship at my same institution. I guess what would be your recommendations for folks looking to potentially stick around at their home institution for a fellowship, or for folks that want to try and do an enfolded fellowship? I guess how is that viewed in your respective fields for folks that, I guess I'll say for folks that want to go into either academics or private-demics as a career?
Yeah, I think I'm particularly curious to know how you handle enfolded fellowships versus postgraduate fellowships, especially, which we probably should talk about with CAST and a lot of these fellowships now wanting to be accredited and only having it really count after your, at least after your 6th year. How do you handle what to do with your middle years if you love spine,
Okay, so I mean, I would say it's a very controversial topic, and I like it, and I like the issue of CAST. And there are a lot of particulars, whether they're billing for your services or not, how many fellows there are, and all that. I can tell you, in Miami, we tried to find an equitable balance. So if you do an enfolded fellowship before your PGY 7 year, you're doing 2 years. If you're doing a post-residency fellow, it's 1 year. So you can weigh the balance on that a lot of different ways, and everybody's going to 6+1 anyways. So this is a very quickly evolving field. But I would say that, if you haven't done a chief year yet, of course, it's not the same experience. There's no way until you've done that year as chief that you can get as much out of it. And that's why we require 2 years for the pre-chief fellows.
Yeah, for vascular, it's a little bit different because we sort of have these 2 staged. Our actual fellowship's 1 year, but there's an official kind of pre-year you have to do. So it lends itself to doing that pre-year during that gap, what are the traditional PGY 4 year, whatever that is. That said, what I tell our residents is the last thing you want to do is waste. We've changed the term to an enrichment year for that year, the last thing you want to do is waste this magic year in the middle of your residency where you can learn so much by just doing a clinical fellowship that you can do anyways and probably should do later. So if you want to do some things to prepare, do some sort of insult to spine, or do your first year of endovascular where you're doing 250 angiograms, that's fine. But you should take the time to make sure you're doing something that makes you special and unique, and not just the same kind of surgery you're going to learn to do anyways. You know, work to get a master's, or learn how to do clinical trials, or work in a lab and do some meaningful basic science research. This is, again, like we were talking about before, about this is your period of maximal flexibility. Once you're a few years out of residency, most of us become pretty stiff and stodgy and are stuck in a path on some level, right? We de-differentiate, de-differentiate as we go down, right? We become less pluripotent. And so when you're a PGY4, you should be thinking about, what can I do that's really tremendous and significant and different, and is going to make me stand out from the crowd and give me things that I'm not going to be able to learn later when I'm practicing. So that would be my advice to you. It's okay to do something clinical, but that shouldn't be all you do. And you should really look towards doing something that gives you a unique experience from your residency.
That's a great answer. How do you think about this, Dr. Grant?
Yeah, I normally advocate to really try to go elsewhere for fellowship. You know, you've had this family in your residency, obviously you're very close to, it's part of your legacy, your whole career. It's really neat to have another whole family to have it, you know, on your back pocket for your career. You learn different techniques, different ways of doing things. This is really your last time to do that before your faculty position or wherever you end up. And it's just a great opportunity to try to learn new tricks. And so I really advocate for that. We've had some residents that just for family reasons, it made sense to stay and do their fellowship here. And that's fine. That's great. You know, it makes sense. But if able, I really try to encourage that. I think it's just best for their career long-term. I learned so much at different places that, you know, you just, as you learn as a resident with your different attendings you have, and it's even in fellowship, it's so focused. You're really able to just focus on whatever it is, endovascular, spine, and skull base. You know, it's just such a great year to do that. And I think the more senior you are, the better. That's why we push toward this cast, you know, as later in your residency as possible. You know, I've seen our residents go through this as an R4 versus an R8, R7, totally different experience. The level they could really take that year, I think, is tremendous. And if they can't get that opportunity, I send them, like I sent a resident down to be with Mike, you know, for a month to get another taste, because they just didn't have that opportunity. I still think it's worth it, but they just can't get that full year, you know, to do that.
If someone wants to go into pediatrics and they're PGY 2 or 3, what would you counsel them to do with their middle years? I've seen people that want to go into pediatrics spend a lot of time with the pediatric hospital in their middle years, a variety of things. I'm just curious, what would you encourage people to do with those middle years or middle year?
Well, I mean, at Stanford, we're pretty strict to really dedicate that time. We have 2 years, you know, that's protected. So they're doing something pretty, I think, unique and special no matter what they're doing. It's a lot of depth to it. And that doesn't mean bench work necessarily. It's just something that is going to contribute toward their career, whatever they do. They become real experts in something and work with incredible mentors. A lot of them are on the R25 or global health, whatever. There's so many different opportunities that they're doing, but I think it's following their passion, and we really work with them to make sure it's going to be something useful for their career. And it's way beyond peds. I mean, it doesn't mean they have to do work just related to pediatric stuff. I just love hearing about, you know, their passion and what they're doing. I wouldn't think about it as what's going to get the best fellowship. I think your dedication to publishing is important in peds. That shows you have a track record toward wanting to do work in pediatric, you know, subspecialty work later. That really helps you, and working with your mentors for clinical projects or translational things. All that's really important. But I wouldn't just say, okay, this whole time I'm going to do just in peds, because it's really the subspecialty in peds that's more important. There might be a niche that you're going to go after, such as we have someone doing peds, but wants to be a functional DBS person and, doing incredible amount of translational DBS work because they want to be a pediatric DBS expert, so it's that sort of thing I would go after and not just sort of general peds interest, if that makes sense.
Perfect. Dr. Raza, I'm curious to know how you handle the idea of doing enfolded fellowships. I don't think you allow them there, is my understanding, but would you encourage someone to have more time in an enfolded fellowship type situation in their middle years if they're going to do a postgraduate fellowship, and how would you handle that question?
Sure. I mean, speaking from my personal experience, I did an enfolded fellowship on a T32 grant. So part-time is clinical and the rest was research. And then of course did my postgraduate skull-based fellowships. And from the clinical standpoint, I can say that I got a lot more of the fellowship experience post-residency. I don't think I really got much out of it during my enfolded fellowship. And I think the reason why, there's something to be said for having completed your spine experience, your vascular experience, your oncology experience, and then pursuing a fellowship. So my understanding of managing craniocervical junction malignancies was much more advanced as a fellow than a PGY5 winging it and saying that I was doing a fellowship experience. I think if you're going to pursue any sort of inter-residency experiences, really, I would focus on developing that academic skill set, whether it's clinical trial design, healthcare economics, whatever. I think that's a valuable opportunity to do that and save the advanced clinical training for after residency. And that's part of the reason why we don't offer enfolded fellowships at Anderson.
Yeah, I think that's 4 out of 4. I think everybody, if someone does some of their clinical time in that subspecialty in their middle years, everyone is an advocate of doing a full year after their training, it sounds like. So I think that's the way everyone's moving nationally as well. Anyone else on the panel have questions for our panelists, for our speakers?
Yeah, one other question I would really like to ask. We always come at these panels from the perspective of the applicant. How can we make ourselves better? How can we improve our CV or our application? Which kind of makes sense, as I think most of the anxiety in this process comes from. But just to kind of flip the perspective a little bit, what should applicants be looking for in programs that would set the program apart from other fellowships? I've got my own biases, but I'm curious what all of you guys would say in terms of what applicants should be looking for in the program as they're kind of ranking places in where they may want to go.
David, I think that depends on what they're looking for, right? So Dr. Grant said it really well earlier, how it's a relationship, it makes sense, it feels right, you meet the right people. A lot of that speaks to, we can tell you what we are looking for, but it also depends on what the applicant is looking for. I'll tell you, our fellowship is incredibly busy. It's hard work. They're taking a lot of call and they're doing a lot of cases, and that's not for everyone. Some people want a fellowship where they're not over. In fact, I remember getting this advice from someone: don't go to a place that it's too clinically busy, because you want to have time to read and think and do something else. I think our guys are reading, I think guys and girls are reading and thinking as well. But the point is that there's different fits for different people. So I would tell your theoretic applicant to sort of search their soul as to what they're looking for. Are they looking for mentors that are politically connected? Are they looking for a place with a acknowledged translational program because they really want to be translational scientists tied to their clinical? Are they looking, what kind of clinical and academic and holistic experience do they want? We're adults at this point, right? We talked about before, this is life. It's no longer about jumping through a hoop. It's about you figuring out what you want and what's going to be important to you, and then finding the program that fits that.
Yeah, I would echo that. And I would say that you have to kind of get a sense of what you're really trying to get out of this. And, there is this thing about the stage in your life for doing the right thing. And, when you're in college, you're supposed to do a certain thing. When you're an intern, you're supposed to do a certain thing. And when you're a junior resident, you're supposed to do a certain thing. You're supposed to learn these things. When you're a fellow, that's a very unique role. It's not a chief resident role. It's not a resident role. It is a different type of a situation. And so some people are going to pick a fellowship because they think it's going to set them up for an academic career, right? So these are the folks that are going to get you involved in organized neurosurgery. They're going to teach you how to write grants. They're going to get you set up in a network of trials. and all of that. Other people are looking for the technical masters. And you know, everybody wants all these things. But the problem is, if it was that simple, then it would just be one fellowship in the country, right? And some people are going to want to go where their lifestyle, their families, or where they're going to pick their first job, right? They want to be closer to that so they get approximated to it. Some of them, it's a year-long interview for a job because they really want to go work there, right? So I think that there are a lot of elements at which people arrive at the end of residency. Let me just add one thing though about those middle years, because I love that. I don't want to say spine surgeons are less academic, because I don't feel that, but I'm just going to make the countervailing point that sometimes those middle years are good for like having a baby, or like, you know, broadening your perspective, or getting a master's degree, or whatever it is. It could be something different than just trying to be more neurosurgical. And you should be open to that, I think.
These are outstanding answers. Maybe Dr. Grant next.
Yeah, I was just thinking about some things. I mean, one thing that's important is, as Mike brought up, that your role is very different, and you got to make sure that you're going to get enough autonomy, you know, as a fellow. That's where it really matters, because this is your transition to independence. And if you're not getting that autonomy in that year, that's so crucial. And you have to be elevated to that level as a fellow, that you're going to be respected as a junior attending, really, because that's what you want, to get that kind of independence early. And you're going to get time alone in the room. You know, this is time for you to grow in a way you couldn't grow as a resident. And then there's, of course, general and specific issues. Like everyone, as I said, has to do a certain number of cases and a certain diversity of cases, because it's part of the certification to be a pediatric fellowship program now. It's very strict. You have to have a certain number of mild meningocele, say, or spasticity cases. You can't just say, oh, we do a lot of tumors, and that doesn't cut it anymore. But, you know, you might have a specific interest that you want to make sure you're going to go to this place because, gosh, that's something you really want to be able to do, such as, say, moyamoya disease. Not a lot of centers do a lot of that, for example, you know, so that's something here that is very unique, I think. And last is that I think it's different than if you go to a fellowship to work with one-on-one, say they work with Mike, you know, you're Wang's fellow. It's different in peds. You got to make sure the attendings all get along. If they don't, the fellow is caught in the middle. And I think some programs stand out because that's not the case. And I think it really hurts the fellowship, because then you're having to, you know, field all that during the whole year of what's going on. And you just don't want to deal with those politics. You'd love to have a community of attendings that really work well together if you're attached to more than one person. I think that's, in a fellowship, really important, because you're too junior to take sides.
Another great aspect of this. Shaan, what do you think? Any other thoughts?
You know, I agree with everything that's been raised. And what I'll add to that, ideally, you want to head into a fellowship that's going to prepare you for the future state of that subspecialty, right? So, for example, if you're looking for skull-based fellowships, you know, when you're done, you want to be well equipped in the full spectrum of open and endoscopic skull-based surgery. That's where the field is. If you're looking for a general neurosurgical oncology fellowship, you know, thermal ablation, all those techniques, they have to be part of your armamentarium. And so you don't want to be antiquated the day you finish fellowship. And so I think looking for a fellowship program that's going to provide that framework for the future, I think is just as important as everything else that's been raised.
Another excellent point. Christina or Angela, do you have any other questions that you guys wanted to bring up that we haven't covered?
I did want to interject in response to the last question, something when I was interviewing, advice that I got that I found particularly useful, at least for skull-based. I think case logs are useful because you want to make sure you're getting enough kind of that breadth in those particular approaches that you're doing a skull-based fellowship to learn. So if someone is doing quasis and paralaterals and those sorts of things, you want to make sure you're going to get that exposure. And you can usually get a case log from the prior fellow. And I think talking to prior fellows is also useful because, no offense to the guys on here, but people can say what they want to say about their fellowship, but you want to know that your learning style meshes with the person you're going to be working with. And that, you know, some people respond better to criticism and other people respond better to positive feedback and those sorts of things. So I think you want to be somewhere where you're going to be set up to be successful and not be miserable for that year and just checking off a box. So I think getting along with the person and how they are outside the OR and inside the OR is important. So I think I would encourage talking to other people. I think there's some questions in the chat if nobody has any here.
Yeah, I was just going to give Christina one chance to pitch in any other questions or thoughts you had.
Yeah, someone briefly mentioned talking about fellowships are helpful for if you're intending to go into sort of an academic or private career. I think one thing that I've noticed or kind of run into is sometimes you're almost simultaneously doing the job search and the fellowship search. So I don't know if there's differences sort of between specialties and like in regards to the timing of these things. I guess I'm sort of only familiar with the spine world.
I think it may vary fellowship to fellowship and maybe even specialty to specialty. Dr. Grant, do you ever have that situation in peds, since you guys are pretty late, where people are looking for jobs and fellowships around at the same time?
Yeah, that comes up, and we had a little bit of a problem in peds. There was one year when people were trying to woo people in for their fellowship, saying, "Oh, we also got a job, and we can try to just pay you more during the fellowship and entice you to stay." That can't happen. And we had to shut that down because when we found out about it, it really taints the fellowship process in terms of the match. It shouldn't be about the job. It's nice if someone, say, wants to come out and practice in California eventually, and they're here in fellowship, great. That makes sense, but not specific to, I'm coming there because I want a job there. You have no idea how it's going to go that year, or what the needs are, could change. And so I think that's a really good point, that you brought up. It's really focused on the fellowship.
Those are great comments. Did you have any questions that you wanted to bring up, Angela, from the chat? I think you're muted.
There we go. I don't know that much about this, but someone was asking about trauma and neurocritical care fellowships. I don't know if anyone here feels the need to.
Well, I can briefly speak to that. I just mentored one of our residents through that process, and he's going to take a trauma neurocritical care fellowship this next year. He's chief right now. I don't know exactly what the question is. I think the question was sort of vague about what about these. I think they're a great way to go. They're a great opportunity. Sorry, for some reason my children have come near me and are deciding to have a Nerf gun fight. One sec. There we go. Hopefully that works. We'll see if they listen to me now. You all know whether or not my kids actually listen to me. But in any,
what did you actually say? I wish I could.
Not safe for webinar.
Yeah, exactly. But in all seriousness, I think it's a fantastic type of fellowship to pursue. I think it leads to great opportunities. There's lots of opportunities in research. There's great opportunities in terms of quality of life and balance and other things in the field. And frankly, they do amazing things. Really do some pretty big time life-saving things. So I would encourage people to pursue it or look into it. There's a bunch of good ones out there. Miami's is a traditionally great program. UCSF is a great program. Maryland has a great program. These are just random ones I'm throwing out there. Definitely take a look.
And I would add that trauma critical care, I think you can do the fellowship enfolded and still get full credit with CAST. I believe so.
That's correct. That's correct, I think.
Yeah, I believe that's changing soon, is my understanding, or is in evolution. But right now, I believe that's right. If folks want to hear a little bit more about trauma specifically, we actually just did, and it should be out in the next few weeks, a podcast in our kind of like sister podcast called The Neurosurgeon's Journey, going over some issues related to trauma and fellowships. Not quite as specific as this webinar, but something along those lines. It's another resource you may want to look into. All right. Any other questions that we may want to cover from the audience? I think there's a question, Dr. Grant, about pediatric neurosurgery and the international match. Do they match through the match system, or is it some other way that they can get into U.S. resident fellowships?
Yeah, they can go through the regular match. They just have had it done their USMLEs because they have to get, a license in the state. But they do that. Toronto, for example, it's unique, I think, because they have two fellows. They have their matched fellow, then they also have another international fellow. It's interesting. So they're always the two. So that's just one unique place, I think, that always has kind of an international fellow with the matched fellow. But they could come just like anyone else. And we've interviewed people outside. I'm not talking about Canada, but, you know, beyond around the world. And, you know, I think it's great to get them in the mix, especially by Zoom this year virtually. It was really fun, you know, meeting these folks around the world and hearing their story.
All right. Yeah, I think it's worth kind of going over. We touched on it a little bit, but it's worth going over in each of your subspecialties. What's the role of being CAST accredited? Is it something that you probably would want to target if there is CAST accreditation in your various fields, or is it kind of something that's nice but not a must? Maybe we'll start with Dr. Raza on this one.
I would say probably not much of a role, in all honesty. I mean, it's nice, but not a must. There's so many great fellowships out there, both in skull-based and in oncology, that are not CAST certified, that are outstanding fellowships that I would recommend to anybody. So, and in terms of looking for a job afterwards, not much of a role either, because these aren't mandatory fellowships to get a job in oncology or skull-based either.
Right. Dr. Wang.
Yeah, I think, you know, that's a good point, because CAST accreditation, we've been trying to have that be a major touch point of what we do in training. Of course, that battles against the idea that all neurosurgeons are essentially generalists, except for peds, right? And even with peds, we can take care of the basic peds, right? That's the idea, and that has to be the party line for a little bit longer, anyways. CAST hasn't really taken off in that way, with all due respect to Charlie Branch and Vince Trinellis and all these guys who've tried to push the CAST program, and unfortunately has no teeth. So there's really, in effect, no difference between a CAST accredited fellowship or not. And neurosurgeons have traditionally also been very good about grandfathering people in. In other words, the folks who didn't have to do the board renewal, who were just a couple of years ahead of me and Jerry Grant, they never did a re-up on their board certification, right? Like, you missed it by a year, and those guys just took the boards as a young attending, and that was it for life. So I think the neurosurgeons have classically been taking the party line that if you did a fellowship that was not CAST accredited before the time at which it was something changed and you really needed it, they're not going to really hold this against you. And I think that's going to be the way going forward. I think it's a nice concept. It's sort of like an extra stamp of approval, but I wouldn't make the decision based upon that.
Perfect. Dr. Mocco?
Oh, he stepped off. Oh, is he here?
No, he had to pop off.
Yeah, no problem.
From a vascular standpoint, they always talk about it becoming an issue for reimbursement down the road, but I don't think it's anywhere close to that from a legislative standpoint. So I think, much to Dr. Wang's standpoint, if you get certified now, I mean, you'll be grandfathered in if that ever actually becomes a bigger issue. But
all right. And I guess the last question that I think we've seen a couple different times is particularly for Dr. Raza and Dr. Wang, which is like, in your mind, you know, I mean, there's probably the academic jobs, and then there's the private practice jobs. In your mind, how appealing, from what you've seen of your graduates looking for jobs, how appealing or important is it for them to have these fellowships to get these jobs, as the different categories of jobs as they graduate from your program? Like, is this something you need to have as a stamp to get a great job, either in private or in some big group or in academics?
I'll take this from the oncology perspective. What I've noticed is that more and more of the job postings are looking for fellowship, some sort of fellowship training. With regards to the skull-based perspective, not so much. But I think it's still a nice stamp to have, and I think, you know, potential employers do view it favorably, of course.
Yeah, I think, you know, it's very individualistic. So if you come from a program that does a lot of spine and is well known for it, I don't think that people really care, right? They want to say, okay, you know how to do these cases and you're good at it and you have the subspecialty expertise. Obviously, if you've done the fellowship, then you don't even have to have that discussion, right? So I think you have to reflect back on what your mentors at your residency program are going to say about you. And that's, I guess, the third reason for doing a fellowship. I hate to even bring it up, but it's getting late. Like, if you feel like you're not getting the support you want at your home program, it's kind of a chance to re-up with a different family. And maybe you're going to reinvent yourself in a better way if that's possible as a fellow. And I think that there may be people listening right now who are in that situation. So I would say, life's not over if residency isn't going so great for you. Maybe you're going to do better in fellowship.
Awesome point. Dr. Grant, I mean, I think everybody has in PEDS has to do these fellowships if they want to do PEDS from an accreditation standpoint in most hospitals in the US. Is that correct?
Yeah, no question. The hospitals won't credential you unless you have that kind of fellowship card. But we've changed our whole residency. Stanford was very strict, 2 years, this for years, but we've just changed to allow this cast, to happen late in the residency. And that's a push that came from our trainees that said, this is necessary, looking for jobs. So I think it's important even now. I think it's something that, they're going to look for that, whether it's avowed or not, who knows, right? We don't know yet. I agree with everyone, but people want that fellowship, and as close to being done as possible will, I think, be a benefit to you. So something to think about for sure.
Okay, great discussion. Any other questions that our panelists have for our guests here? All right, well, I think that may be it. We'll go ahead and end here. I always go through a few slides at the end to summarize things up and get ready for next week. So again, we have on April 8th, we have our next webinar, a little bit more focused on medical students and how they should learn to kind of maneuver through the sub-Is and interview process to do very well. We'll have some good speakers and guests. Well, this Neurosurgeon's Journey podcast I mentioned, and Dr. Wang also has a podcast, but this is more focused on kind of students and residents, although Dr. Wang's is quite excellent. And we do have this trauma episode coming up shortly. It should be out in the next few weeks. I wanted to mention one of the big things in our committee is paying respect to a tremendous person on our committee, Chris Phillips, who did so much for our committee. She worked for the AANS, and we have started an Honor Your Mentor fund in her name, and just wanted to acknowledge her and her contribution. Finally, these webinars are recorded and posted on the NREF YouTube page under a sub playlist of YNC webinars, and those are easily Googleable and findable via search engine. And so you can also hear when this particular episode will be posted. We usually alert everyone on social media, so stay tuned for that. And with that, we'll say thank you to our awesome guests, Dr. Wang, Dr. Grant, Dr. Raza, and then the recently departed but also outstanding Dr. Mocco, as well as our panelists, Dr. Dornbos, Dr. Richardson, and Dr. Wright, and Anna Rodriguez and Becky Stewart who've been such an amazing part to these webinars. I just want to thank you all for coming, and hopefully for the viewers out there, we'll see you in a few weeks for the next webinar. So thank you guys all for coming, and see you next time.
Take care.
Take care.
Thanks, Jeremiah.
All right.